The question is that this bill be now read a second time, and I call the member for Higgins.
Thank you, Deputy Speaker. Deputy Speaker, a diagnosis of cancer is devastating, but a diagnosis of lung cancer is particularly bad. Lung cancer 5-year survival rates are currently 24%. That's woeful. And really, it hasn't moved much in decades. So around 1990, the 5-year survival rate was 10%. And it's bumped up now to 24%. Still very bad. Overwhelmingly, the biggest problem is a late diagnosis. Patients just present too late and they're diagnosed way too late. And by then, the cancer has advanced. 85% of lung cancers are due to non-small cell lung cancer, things like adenocarcinoma. But then there's the much feared small cell lung cancer, which affects 15% of patients and has a propensity to disseminate, often at diagnosis. And the treatments are no picnic. Now, I've seen lots and lots of patients who've had lung cancer. In fact, I've diagnosed many cases myself. And this has often been through incidental testing. So a patient may come in through the hospital with an unrelated problem, say pneumonia or chest pain, and they go through a battery of tests and a lesion. A spot is found on the chest X-ray or the CT scan. And then one thing leads to another. It may be a fine needle biopsy where a needle is put in through the chest wall under CT-guided under CT, or it may be a bronchoscopy where a camera is put down in through the airway and then down deep into the lungs and a biopsy is taken. So it's a fairly stressful period for patients when they know they may be walking around with a potential lung cancer, and then they have to undergo a series of tests, and there's additional waiting, and then the histology has to be done, the pathology has to be looked at before a diagnosis is made. So this is incredibly traumatic for patients. And then, of course, comes the sit down with the oncologist, where the actual repertoire of tests is discussed with them and treatments. And that may range from surgery. Often surgery is required. It may be a lobectomy where a lobe is taken out of the lung, a wedge resection where a piece of the lung is removed, or a pneumonectomy. And I've seen that, and that used to be done a while ago, but the entire lung is removed and it essentially collapses down. That area becomes emptied and the other lung hyperexpands. But patients are not normal after this. They simply do not have the exercise or respiratory capacity. And then there's chemotherapy, there may well be radiotherapy, and nowadays we also have access to immunotherapy. So the treatments are pretty serious, and patients do struggle even through getting through the treatment, and they may not even have necessarily access to any of those treatments if their performance status is not good at the very beginning. So in other words, you have to be able to walk, be self-caring, in order to even be considered for certain types of chemotherapy. If you are not, and this is the case with many patients with lung cancer because they present so late, by then they are emaciated, they've lost weight, they're breathless, they're unable to walk a certain distance. At that stage, the clinician may make a decision that they are not fit to even undergo chemotherapy, and they are then shunted down the palliative care route. And that is an all too familiar pathway for patients with lung cancer. So we, as a federal government, want to change that. The Albanese government has an abiding commitment to pick up the baton that was passed to us from a previous government that took strong action on tobacco control. Australia once led the way on tobacco control, and it was Nicola Roxon, a Labor health minister, who introduced plain cigarette packaging in 2011. And then things went silent. They went silent for a decade under the Liberals, and we saw the ingress of vaping, e-cigarettes. We've seen a rise in nicotine dependency amongst particularly our young people and some children as well. And we currently have smoking rates that are stuck at around 11%. Now, we have adopted the National Tobacco Strategy that was released in June of last year. And that strategy lays out very clearly that we want to aim for smoking rates of 10% or less by 2025. So that's basically next year. Currently, our rates are 10.6 to be precise. And we also want to get to smoking rates of 5% or less by 2030. So we don't have a lot of runway, and we have a lot of public health work to do. But one of the key things we do want to do is save lives in the interim. And we are going to do that by introducing a national lung cancer screening program. Now, screening for cancer is familiar for those for cervical cancer and for bowel cancer. Lung cancer will now be added to the national register. And this has come about thanks to tobacco excise duties that will be paying for this initiative, a world-leading initiative. And in addition, we have taken on board the advice from our medical advisory committee. So patients who have a long history of smoking, who have been heavy smokers, usually 30-pack years, that means 1 packet of cigarette a day for 30 years, who are aged between 50 and 70 will have access to screening. And that will be done through a low-dose CT scan of the chest. This is a non-invasive test. It is really no big deal. People lie in the machine, there is no contrast given, and they're in and out within minutes. No pain, very straightforward. In fact, easier in some respects than a chest X-ray. So, and it's a higher resolution test than a chest X-ray. So it will likely pick up any malignancies at an earlier stage. And why is that important? The 5-year survival rate for stage 1 lung cancer which is localized to the lungs, in other words, hasn't spread to the lymph nodes, hasn't spread to the adjacent organs or spread into distant sites in the body, is actually 67%. It's very high. It's completely different to the current 5-year survival rates of 24%. So we do want to pick these cancers up early. The program will also be open to past heavy smokers, people who have quit in the last 10 years. And these patients will have access to a 2-yearly, that's a recommendation at the moment, 2-yearly low-dose CT scan. And we think that this will make a material difference. It will actually save lives. At the moment in Australia, we estimate that around 15,000, there are 15,000 new cases a year of lung cancer diagnosed, a slight propensity towards men compared to women, and that results in around 8,700 deaths. So this screening program will save lives. That's the point of it. It will save lives, and it will save patients from burdensome, toxic treatments, because it's so much easier to resect a nodule or blast it with chemotherapy than to go through, or with radiotherapy, than to go through arduous chemotherapy, which it's pretty grueling stuff. We estimate that this screening program, Deputy Speaker, will prevent more than 500 lung cancer deaths per year. And this is particularly important for vulnerable groups, priority groups in our community, and I speak particularly of First Nations communities. In First Nations communities, smoking prevalence rates are up to 60%. 60%, that's 6 times the national average. And we already know that our Indigenous brothers and sisters die, on average, 8 to 9 years before the rest of the population. And much of that is being driven by the harms associated with smoking. Now, tobacco smoke contains over 7,000 toxins, and it's not just lung cancer that is the only harm of health hazard associated with smoking, because smoking can actually trigger cancers in any part of the body. So it's often seen in patients who are heavy smokers that they will have concurrent malignancies. They may have a head and neck cancer as well as a lung malignancy, or a bowel malignancy, or cervical, and so on, and so it goes. So this, it is incumbent upon us as a government to not drop the ball on this, and I really hope we have bipartisan support on this, because it is in the interests of the nation that we drive down smoking rates. And for those people who unfortunately have been entrapped by the scourge of addiction, we want to make sure that they have access to the best available technology, and if they are at risk of lung cancer, that we pick this up early and we save their life. I wholeheartedly commend this no-brainer bill to the House. I am so proud of this Albanese government to have brought forth this world-leading lung cancer screening program, as it will save lives. Thank you, Deputy Speaker.
The question